Good afternoon, everybody. Welcome to Bioethics Grand Rounds. My name is Naomi Leventhal. I'm a newborn intensive care doc, and I'm one of the faculty ethicists in the program in clinical ethics. It gives me more pleasure than I can really articulate to introduce Stephanie Kukora as our guest speaker today. Nothing warms the heart like introducing your former mentee as a fully realized neonatologist and ethicist who doesn't need you anymore. We were fortunate enough to recruit Stephanie as faculty here in neonatology in 2015. Before that, she got her Bachelor of Science in Chemistry in 2004 from Haverford College, went on to get her Doctor of Medicine from University of Texas Southwestern Medical Center at Dallas. She completed her pediatric residency and neonatology fellowship here, and she's also completed the Children's Mercy Bioethics pediatric certificate. She finished that in 2014. Dr. Kukora has really established herself as a really successful bioethicist. She's developed a lot of really interesting lines of research. Today she'll talk to you about global health, and I'll leave that to her, but she's also done some really compelling work in value-driven shared decision-making in the newborn intensive care unit and using improvisational theater techniques to teach physicians empathetic and effective communication. I don't want to take any more of her time, so please join me in welcoming Dr. Kukora.
All right, thanks everyone for being here. I'm going to be talking to you guys a little bit today about some research that we're doing that involves some of my ethics research at home, but also branches out into global health. And I'll sort of preface this by saying I'm myself a little bit new to global health. I've only been involved in it for a couple of years myself. When I was Shane Quinones from Pediatrics reached out to me and said, hey, you know, St. Paul's is interested in having some subspecialists, and my division said, Stephanie travels some scary places, so why not? And so I was like, this sounds great. So I really enjoyed it. I find it really rewarding. And I'm really excited to share some of the preliminary work that we've really been working on. And so in my presentation, I'll have beautiful pictures from Addis, which I think is one of the most beautiful places I've traveled to. I do not have any photos from Ghana because I have not been there yet, but maybe in the future. All right, unfortunately, there is not big money in pediatric global health. Wish that there was, but there is not. Okay, and so the really big problem here is that of justice. And so I think Martin Luther King said it best when he said, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. And what I'm talking about is that many of the life-threatening illnesses that affect newborns have been increasingly treatable over the past few decades because we've developed things like mechanical ventilation, antibiotics, total parenteral nutrition, and advances in pediatric surgery. But unfortunately, worldwide, not all the infants receive the life-saving treatment that they need. We've seen a tremendous decline in neonatal infant and child mortality in the US through the 20th century. And now in the US, most of neonatal ethics focuses around whether or not we should be saving these very, very premature 22-weekers, very rare. So people like John Lantos, who's one of my mentors, weighs in on, should we be saving 22-weekers? We don't know. And for perspective, this is like 0.1% of the births that happen, that we spend all of our sort of ethics time worrying about. But that seems a little bit, blinders on, because we know that worldwide newborn mortality is still a huge problem. And so the World Health Organization had
recording is on.
And we kind of met some of them. We had a really good decrease in early childhood mortality between 1990 and 2016. But the proportion that are from neonatal deaths has risen steadily because we have not had the same advances in newborn deaths. About 2.5 million infants die in the first month of life worldwide, and neonatal deaths worldwide comprise almost half of the deaths of kids under 5. And then 2/3 of the newborn deaths are directly related to a lack of quality care and resources in the perinatal period. So these are fixable issues, but they're just not being fixed. And so for comparison, our infant mortality rate in the US is about 5.7 per 1,000. In Ghana, this is about 34.1, and in Ethiopia, 48.3 deaths per 1,000. And where you live matters, but these are problems everywhere throughout these countries. And so when I tell people that I go to Ethiopia, I think that they picture that top picture, which is in Ethiopia, and they say, "Wow, it must be crazy taking care of babies in a place with no floor." And I'm like, "No." That's not really what I do. They say, "Wow, you must be so brave." I picture the bottom. Addis is a big city. It's a huge modern city. And so infant mortality in Ethiopia is much higher in the rural areas, like the top one, more than 10 times what we have here in the US. But even in the urban areas, in the best hospitals, it's still about 6 times higher than what we have here. And a lot of the problems can be attributed to variation in the supplies, the education and training, and the availability of the providers to provide that care. And you may be saying, but neonatal care is super expensive, and it's true. In the US, we spend about $26 billion every year on premature birth. Most of it's healthcare costs for the infant, some of it's costs for the mother, early intervention and special education services, and then we lose a lot of money in work and pay for people who were born prematurely and have disabilities for life. But we do know that the money that we spend for neonatal care is actually really worth it. So about 1% of the 4 million infants who are born annually weigh less than 1,000 grams and are less than 28 weeks gestation. And 0.6% or 24,000 of those don't survive. But of the, if you look at what the resources are expended on, the resources that are expended on, the doomed infants versus, the allocated. So these are the sort of percent that don't survive at these birth weights, and these are the resources that are allocated to the ones who don't survive. So we don't spend oodles and oodles of money on the kids who die. You know what I mean? Usually the ones who don't survive die pretty quickly. And I would argue that of the 3 million people who die in the US each year, fewer than 1% of those are neonates. The other 99% are adults. And the difference is that the neonates with the longest stays are typically survivors, while adults with the longest stays usually die. And infant survivors can gain their whole lives, and adult survivors typically get few. And so here's the sort of resources expended for doomed adults in the ICU. You can see that the ones who die actually get all the money spent on them before they do so, as opposed to the survivors. But in some parts of the world, expensive is still expensive. And so we have to sort of consider how to balance the costs against the benefits of these interventions in settings where there are limited resources. So I would say that many of the therapies that we have for critically ill infants are not terribly expensive in themselves. Things like attending deliveries, neonatal resuscitation, antibiotics, and IV fluids, things like CPAP and as respiratory support. But the thing that's really important is having the right providers who have the skills and can determine who will benefit from these therapies, can allocate the resources appropriately, and can decide when we sort of reach this point of beneficence versus non-maleficence. Unfortunately, global newborn health has taken a sort of different approach to this than what seems to be needed. Much of the work has focused on the newborns dying of birth asphyxia, so the kids who sort of come out of delivery and don't get resuscitated. That is a big number, it is a problem, but a lot of the work has focused on training these birth attendants in a very simplified version of neonatal resuscitation, like helping babies breathe. And while this is a great idea, we found that these sort of one-offs, I show up, I teach the course, and I leave again, has led to very poor acquisition of skills. Like, it's hard for these providers to pick this up. And then when we check back with them, they're not using them in the real world. And then if you check back in a year, like, nobody even remembers that this was done. And so the success rate has been pretty low, but this is still, I think, probably one of the more common approaches to newborn global health that's being done in the world. The other thing that's being done is that global health foundations and NGOs will donate lots of stuff, equipment, medication, supplies, but unfortunately don't really invest as much in the training of people and how to use, maintain, and repair this equipment. And then it falls into disuse and actually contributes to Africa's huge growing trash problem. So, we send them, we say, hey, we're going to send you lots of equipment, and then something breaks and there's no one there to fix it. It goes into a room. Years later, people are like, oh, we don't even know what this was for anymore. Or you train one person to use this thing, and that person leaves, has a baby, dies, who knows? But they're gone, and now no one knows how to do this. So one of the things that I've been trying to work on is how can we change the focus? And we know that the idea of ongoing partnerships that target capacity building and in-country education of subspecialists has the potential to be more impactful on this survival than equipment, technology donations, and short-term neonatal resuscitation training. This is sort of the idea of longitudinal mentoring of fellows in their own environment, creating neonatologists that can teach their own future fellows, and then that develops into the country's self-sufficiency in maintaining this as a specialty training, and then going on to sort of implementing evidence-based neonatal care throughout the country. And the idea of capacity building is that it takes a specialist to train a specialist. We have academic and professional partnerships that create the content expertise for training physicians to become those specialists. And specializing, it gives a lot of advantage: efficiency and organization of clinical care, practice and protocol standards, policy development, guidance of national research initiatives in these areas, and advocacy with the government to support these efforts. And this involves a lot of things: infrastructure support, curriculum development, certifying. How do you know when somebody has done their training and ready for independent practice? Outreach, research, outcome evaluation, and quality improvement all contribute. But there are a lot of challenges to how we do capacity building. Do we give new skills to people who already work there versus recruit new people? Do we teach them the skills themselves or the skills to teach those skills? So do we train fellows to become neonatologists or neonatologists to become fellowship directors? Do we train researchers to do neonatal-focused projects, or do we train them to design their own research? How would we measure success in this realm? How do we ensure equality in these kinds of partnerships? Not just, people from here coming and saying, here's how you should do this, but having, all perspectives heard. How do we develop goals that are meaningful, achievable, and sustainable to local stakeholders that are mutually beneficial for both places? And so these things are really hard to answer. These are big questions. So now I'll talk a little bit about Michigan and our partners, and a little bit about what we're doing. If you haven't seen our unit, we have a beautiful NICU up on 8 Mott. It looks like this. We have beautiful independent rooms with a view of the ARB, nurses, great space. We have 46 beds in a 6-bed step-down unit. We get lots of admissions. Many of them are inborn, but we have a lot of out transfers. These numbers are old, so they might be a little different. We have 9 fellows, 3 per year for a 3-year fellowship. In Ethiopia, we work with St. Paul's Hospital in Addis, which is a large urban public hospital. They have about 1,000 deliveries per month. So that is more than 3 times what we have here. They are an academic center with a pediatric residency program, and they have had a long-standing partnership in multiple specialties, including pediatric and obstetrics. So neonatology seemed like the nice bridge between those specialties that could fill the gap. This is their NICU, but hopefully not for much longer. You can see there's a lot of space issue. That's me. I'm the giant in all the pictures. I'm so big there. But the babies are sort of crowded. They share things like Billy lights and warmers. The moms are often there. So there's a way to go. But the good news is that they're getting this great new children's hospital, and it is opening really soon, in 2 weeks. Which I've been told for, I think, close to 2 years now. But we are waiting. It's getting closer and closer, and we're so excited. And in the new unit, they are destined for oxygen and air so that they can have CPAP and ventilator capabilities, which they really haven't had before. They're going to have a lot more space. They're going to be able to separate high acuity and low acuity outborn and sepsis, and have a lot for kangaroo care. And ideally, we've been promised that there will be more staff there will be more consistent supplies, but I'm also worried that it will be more babies, because if you heard that this new hospital with the state-of-the-art NICU is opening up, it's probably where you'll go to deliver, and so the capacity might be a problem. So we've been doing some capacity building at St. Paul's, supporting fellow and attending education, learning, teaching people to teach advanced neonatal resuscitation. We have a visiting rotation now, inaugurally this month, for neonatologists to come to Michigan. This is Dr. Mallette. She is here for the month. You can see her. She's in the photo here too. We've been sort of talking through how we address some of the challenges of developing better in-country training for neonatologists there. Things like technology limitations, right? Like all neonatologists should be really proficient in ventilators, but what if you don't have ventilators? How do you train people with that? What if you don't have neonatologists to teach you? It's easy here. I have lots of really bright neonatologists teaching me, and then the certification procedure. Like we know here what it means to be done, you know, what it means to have achieved everything you need to, but in a place that doesn't have these standards, how do you go forward with that? We've also been trying to support clinical care through didactic lectures, nursing education, technology implementation, and protocol development. So these things are all very exciting. We've been supporting infrastructure with the new hospital planning and administrative education. We've been supporting research with, we've been doing qualitative interviews. We're working on a new project to monitor neonatal seizures and manage them better. And quality improvement, we have partnered with another team of neonatologists who also have been going to St. Paul's actually far longer than we have at Michigan, called Wax and Gold, who have been doing a lot of work with neonatal resuscitation, nursing education, hand washing, and they are all QI experts. So they've been really great at moving this forward. So here we are teaching neonatal resuscitation to the residents, which was really fun. Okay, the Ghana partnership. So I'll sort of, you know, I told you I haven't been to Ghana myself, but we've done some work there. So my fellow, Dr. Charla Rent, who recently finished and is now an attending at Duke, went to Komfo-Anoke Teaching Hospital in Kumasi. This is their unit. They at least have some individual beds, but there's still a little bit of, you know, limitations in space and resources. Here they have rooms to separate the infants based on age and severity, but they still have very few, they don't have a lot of nurses. They have about 10 nurses in the whole unit to cover, you know, 8, 12, 30, 12. That's a lot of infants. They have a few residents and a couple of attendings each day to supervise, but the number of providers is a really big issue there. And in Kumasi, the training has been, one neo was completely trained in South Africa in a real fellowship project. A few of the neos have gone to England for 1 to 2 years each, but not in a formalized fellowship. And they have residents from the Ghana College and the West African College of Medicine. U of M has a really excellent history, though, with Ghana. In 1986, our obstetrics and gynecology department became involved in medical education in Ghana. And the problem was really that there was a low in-country retention rate. There wasn't a way for OBs to train in Ghana, and they would go elsewhere, and then they wouldn't come back. And so there were, I think, only there was only one obstetrician practicing in Ghana in 1991. What we did was, and it's not me, it's Michigan, mostly Dr. Johnson, establish a postgraduate training program in OBGYN, and they've had this tremendous success rate with more than 90% passing their certification with the West African College of Surgeons, and they now have a couple hundred, I think, like around 200 on the last count, practicing obstetricians in Ghana, which is huge. We've done a little tiny bit of newborn work there. Dr. Moyer has done a lot of research on newborn outcomes. Charla and our partner there, Dr. Ashura Bakari, have been doing the qualitative interview project that I've been involved in. Shane Quinones is working there with pediatric genetics, and one of our MFM fellows, D'Angela Pitts, is working with MFM there and to do sort of bridging that includes neonatology's involvement with the MFM training. And we're working to see if we can convince Ghana that they want to start their own in-country neonatology fellowships. So I've been in talks with Dr. Johnson and some people there. All right, so now I'm going to go switch gears a little bit and tell you a little bit about the research that we've been doing. So this project is an interview project that we've done looking at perspectives on periviability. So a little bit of background: gestational viability is the state at which fetal maturity ensures that there's a chance of extrauterine survival. And this depends a lot on fetal lung maturity, birth weight, maternal management throughout the pregnancy, and the resources available to support the premature infant when born. And we right now, there's a margin of viability where we sort of decide whether or not to intervene. And the idea is that when we think that the burdens are bigger than the benefits, we don't really offer resuscitation. When we think that the benefits clearly outweigh the burdens, we generally move forward with it, and it's not really a choice for anyone. But in the center, where outcomes are uncertain, we consider but don't obligate resuscitation, and a lot of the decision making is shared with parents thinking about these long-term outcomes and what to do. And so institutional and national guidelines exist here in the US to help guide providers in what we should do at these very early gestational ages. And so while there's a lot of variability at about 22 and 23 weeks gestation, by about 24, 25, 26 weeks, it's pretty uniform, and we resuscitate almost all of the infants. And prior to 22, it's pretty uniform again. Nobody is really intervening on these babies. And part of what allows us to have these national guidelines is the regionalization of tertiary care NICUs and this national transport system. And so the care that you get at the University of Michigan or in, small parts of the UP should be pretty equivalent. We shouldn't offer, we shouldn't say, sorry, you're delivering here, no one resuscitates 24-weekers. No, we get, moms to a center where they're closer, we send our helicopter team and we pick up the baby as soon as they're born. And so it sort of solves the justice issue. You're not going to get different care in different places. And so we can have national guidelines that say this is across the board when we should be offering and giving care. But around the world, it's a bit different. In many countries, infants below 28 weeks are classified as an abortion or a miscarriage. And while this isn't sort of necessarily set in stone, it probably arises from the World Health Organization recommendation that those late fetal deaths be included in the stillbirth rates. So, we sort of say, like, if it's less than 28 weeks, maybe you don't have to keep track of it as a stillborn. And people sort of say, well, then that must be viability. About 5% of preterm births occur below 28 weeks. And this probably underrepresents the true burden because reporting of these deaths is probably variable. Where you are, what country you're in, where you are in that country, what kind of provider was there, and their ability to sort of report back. Global preterm deliveries are about 11%. The majority of countries with really high preterm delivery rates are actually in sub-Saharan Africa. And while 90% of infants born around 28 weeks survive in high-income countries, fewer than 10% of these survive in low-income countries. So this is a serious problem. All right, and so the objective of this study was to understand resuscitation practices and provider perceptions of these practices, as well as the factors that influence them at academic medical center NICUs in Ethiopia and Ghana. We did semi-structured interviews in January 2018 in Ethiopia and in Ghana in April 2018. We conducted them in English with the help of in-person translation. We audio recorded them and transcribed them and then analyzed them. Here were the sort of people that we interviewed: the delivery room attendants, midwives, NICU nurses, nurse managers, house officers, residents, physician assistants, pediatricians, neonatology fellows. At the time, there were no neonatologists at St. Paul's, and administrators. Okay, and what we found was that there were sort of two big super themes that were driving people's thoughts about this, and they were sort of in contrast to each other. One was the duty to resuscitate, and the other was the awareness of the resource limitations. And so under the duty to resuscitate, people thought about and told us a lot about respecting all life, religious beliefs, professional responsibility, and learning from poor outcomes to improve over time, taking this as an opportunity to improve their care. And this was a lot driven by the desire to meet global standards of care. On the other side of it was the awareness of resource limitations, knowledge of local and national outcome data, limited equipment and supplies, lack of training for physicians and nurses, and the cultural stigma of disabled children. And so people also were sort of tempted to avoid extraordinary measures. So in terms of duty to resuscitate, we were told by a hospital administrator, it doesn't matter what the law says. If the newborn is breathing, you cannot say it is 26 weeks and a half to let it die. You cannot say that, even though by definition an abortion is before 28 weeks. And a delivery room provider in Ethiopia said, 28 weeks is just a number for us. If the baby is alive, if it's breathing, if he's doing well, we can transfer to NICU. For each baby, we must be flexible. We cannot say, see a baby less than 28 weeks and say, he can die, she can die, I won't help him. That's not good. In Ghana, somebody said, talking about professional responsibility, once there is life, once the baby is born with a life, it is a baby, it is a human being. We have to resuscitate and take good care of the baby. That's our responsibility. And also in Ghana, talking about religious beliefs, if there's life in the baby, so I have to do my part. If the baby dies, it is not me. If I leave it and the baby dies, God will ask me. I didn't swear for that. In my training, I said, I will help you. But this was balanced by the reluctance to go above and beyond. If they come in critically ill, we don't really escalate treatment. We do give them IV fluids and put antibiotics, but to go the extra mile, no. We've never intubated or put a preterm on a vent before. This is a provider in Ghana. And then the cultural stigma in Ethiopia. There is also cultural stigma. Maybe this preterm baby born having cerebral palsy, that the society considers that some sort of sin because his or her family is doing something bad, so that's why God will give them a baby like this. And so we asked people if they agreed with the cutoff of 28 weeks, and some said yes. So in Ethiopia, for those less than 30 weeks, especially those less than 28 weeks, they stay maybe 4 days. Typical is 4 days of life, no more than a week. The outcome is no good. First, I think we need to improve our care and improve our outcomes before we should modify this definition. Otherwise, the outcome will not change. And in Ghana, considering the fact that we don't have a lot of stuff for advanced care, I would say that we keep it at 28 weeks. If we manage to solidify our basics, then probably we can move forward. But other providers disagreed. In Ghana, once a baby shows signs of life, we don't follow the law. If the baby is showing signs of life, if the baby is here, what else can we do? We won't say, if you are less than 28 weeks, we will not resuscitate you. And in Ethiopia, why is our definition for abortion different than the definition in America? It is better to deal with the Ministry of Health. They should deal with that. So this is the desire to meet global standards of care. Survival, though, depends on resources. St. Paul's is a tertiary hospital. We have more capabilities than most centers. If you go to the district, the situation is different. 30 weeks, 32 weeks, they are dying. Mortality is very high. I don't think 28 or 29 weeks would survive. And in Ghana, a 28-weeker here is likely to survive. We don't really think about it at that age. At 25, 26, I think we need to push it. So sort of thinking about all of these things and how they interplay with each other, how would we consider a viability threshold in somewhere like Ethiopia or Ghana, and how would we draw up guidelines that make sense? So revisiting the gray zone, does it make sense to have a guideline that's based strictly on gestational age? Should we make this cutoff something like 28 weeks or something different? And who gets to decide what this cutoff is, and who gets to sort of enforce it or not at the hospitals there? And we have to be really thoughtful about how resource dependent these guidelines may need to be. While our national guidelines exist because of the regionalization, that's not true everywhere. there are 2 ambulances for the entire Ashanti region of Ghana. So moving mothers between hospitals to get to a center that can provide their baby care is not terribly reasonable. There are unreliable supply chains and inconsistent resource availability. So even in the same hospital, what you might have might vary week to week. And so on the one hand, wherever you're born, you should have a right to receive the highest standard of care available to any infant in your country. But that's, maybe not very realistic. But then it would seem unfair to withhold care at a high resource center just because it's not universally available either. Is that a justice issue? And so perhaps you have the right to the highest level of care available at the time of your birth, even if that resource availability fluctuates. But this doesn't make for a nice, clean guideline like we have in the US. And then the question comes up of moral obligation. Because many centers have shown that they are able to resuscitate below 28 weeks gestation, is there now an obligation to do so? Redefining these cutoffs with less strict gestational ages will encourage intervention for infants that are likely to survive, and for many who probably aren't likely to survive, but will also help to move care forward. An ongoing discussion is needed nationally and institutionally to determine at what point we would consider something overuse of therapies and how that would be handled. And so it's also important to think about, in general, even here in the US, gestational viability is a range, and it has thresholds that change over time. And so in other countries, the thresholds must be useful when they align with the cultural context and the resource availability in that region. All right, so switching gears, this is another sort of little offshoot project that came up in our interviews also that we weren't really expecting, but we found really interesting. And so it's about cultural challenges of practicing global health in diverse settings. So as a little background for this, here in the US, we spend a lot of time teaching our trainees about cultural competency. We have decades of working with immigrants and non-English speaking patients. We do a lot of teaching about this to our trainees. And in the training, we are sort of told your patients will be different from you in aspects of culture and race and religion and socioeconomic status and worldview, and that it's our responsibility as providers to bridge these gaps and improve the healthcare delivery for these patients. But when we prepare trainees for global immersion experiences, we say, identify and respect those cultural differences. Do not impose your views. And we're sort of taught, the people there will totally understand the culture. So you just sort of go there, understand that you're super different, let them do all the managing, because they, as the local providers, are much better to manage, these things. So we sort of went into this, Charlotte and I, thinking like, well, we're going to be really different from the Ethiopian doctors who are going to be very similar to their patients. But Ethiopia is really interesting, an amazing place. It's one of the few countries mentioned in the Bible, the Quran, the Odyssey, and other ancient books. It's one of the few African nations that's never been colonized. There are more than 80 different ethnic groups in Ethiopia, and there are over 200 dialects and languages spoken throughout the country. So they are actually very, very diverse. And so when we interviewed these providers, we actually heard some really interesting quotes about culture that we thought were worth sort of chatting about. And so the first sort of was the idea of what the NICU was about and hypothermia. So the first quote here: most of the time, the community believes that if babies have been to the NICU, in Amharic it's called mamokia kifel, which means someplace to warm the baby. They think that they came here because they're cold. They don't think that they have some severe illness or anything. And then a pediatric resident said, they think that being cold is the primary problem. Culturally, they believe this. They think it's the warmth of the NICU that's helping and the cold that gives them harm. And then another nurse said, when we give a medication, sometimes they'll ask us, well, if they're here for warming, why are you giving them medication? There were interesting beliefs that the providers told us about around jaundice. One of the pediatricians said, most of the time here as a tradition, they keep the newborn in a darker room. They think that their eyes are not well developed and they can't tolerate light. And by the time someone sees that there's something wrong with the skin of the baby, it may be too late. And another resident told us, They don't like taking the baby out because of the evil eye. Even somebody looking at the baby can make it sick. They have a fear that if they take the baby outside of the house, someone will give this baby this look. And so for those of you who don't practice neonatal medicine, jaundice is something that's sort of easily treated early with early identification with phototherapy, but if it's not identified until late, can require a lot more intensive intervention. And so not seeing that a baby looks jaundice can have serious consequences. They told us about what they felt, that their patient families felt about congenital anomalies. A NICU fellow said, for herself, of course she will feel that she's cursed. She doesn't want to show it because she feels guilty of having that baby, like it's her mistake. They want to hide it. And another pediatric attending said, most of our moms here are not educated. So when you try to tell them their child has something that can be repaired or something that can heal, it's hard. We try to tell them about the prognosis in their own local language to the level of their understanding. So even understanding what these anomalies are and what they mean is a big challenge. And so other sort of quotes about culture, the difficulty is the language barrier here. Most of the mothers don't speak Amharic. We have a lot of languages in Ethiopia, but sometimes there is someone who speaks their language, but often there's not. And another person, a pediatric resident, said, the staff here is trained in a medical institution, so they have to know where the clinical condition comes from, the pathophysiology, so I hope they're not affected by the local culture. And so what we really realized was that the Ethiopian physicians face cultural barriers between themselves and their patients, much like we do, perhaps even more significant. A lot of these were based on cultural and language barriers, and they impacted patient care and their ability to communicate with families. And a lot of the physicians were sort of aware of the rural cultural practices and beliefs that their patients had, but didn't really have a good understanding of the full history and reasoning behind these practices. But what we were really inspired by was how well the Ethiopian physicians take ownership of bridging these barriers. They depend on themselves and each other to be the cultural brokers. They do not have translators who are there in the middle of the night. They do not have, a lot of the social work and resources we have. And so they would find the member of the team that could best communicate linguistically and culturally, even if they had to leave a busy service to try to track down the one person in the hospital who could explain this. They were very patient in their explanation of the complexities and rationale for NICU care to educate families about dangerous aspects of traditional practices. So they really took the time to do that. And a lot of them, what we were really struck by, found this compassion through familiarity. While they didn't share these beliefs themselves, they would sometimes say that, they could see in their patients their own grandmothers, mothers, relatives who maybe held these beliefs and could sort of bridge that and find compassion for these beliefs. And so our preconceived notions actually shifted a little bit. We were probably a lot more culturally similar to our Ethiopian doctors than maybe they were to their patients in a lot of ways. And so we had a couple of take-home points about culture. It's not binary. It's not sort of us and them. Besides national identities, we're also part of other cultures that aren't based on country or ethnicity, but on profession, education, and shared beliefs. And that the medical community is a big culture in and itself and can be stronger as a unifier than national identity is. Heterogeny exists in our partner countries, and it was sort of naive and, for us to not really understand this before we went. And we should really, as providers engaging in global health, be cognizant of what the cultural diversity is in other countries and work with the local providers to navigate this diversity. And the cultural barriers that are experienced abroad are actually mirrored here at home in our own communities, and that we as providers from the US traveling abroad can really use these opportunities to learn from our global partners how to better play an active role in bridging these cultural gaps. And so there's a lot of people to acknowledge. Thank you all for listening. Dr. Mallet, who's here, Dr. Gessett, Dr. Sarah are all neonatology involved people there. Solimi was the chair of the department and is now an ID fellow. She, if you guys are interested in ethics collaborative projects, she just completed the Kansas City Children's Bioethics certificate course that I took. And I was talking to her about maybe doing shared partner projects across maybe the pediatric ethics committees at both hospitals So if you have ideas for where that could go, we'd be excited to hear it. Dr. Ashura Bakari in Ghana, our Michigan team, Cheryl Moyer, of course, Dr. Charlotte Rent, who did so much of this work, Anne Marie, who's been really taking charge as one of our nurse practitioners, and of course our collaborators at Wax and Gold, Suzanne, Lou, Philip, and Misrak, who've done tremendous work in newborn resuscitation at St. Paul's, working with the administration, helping plan the new hospital there, and organizing trips. So I'll leave you with this. This is the sign at the exit of St. Paul's Hospital. I'm going to butcher this, don't judge me, Mullet. It says, Zare Mene Sarahu, which means, what have you done today? And it urges everyone leaving to reflect on their day and think whether they've made a difference, whether they've been helpful. And if you can't answer yes to those questions, to rethink what you can do tomorrow to make that different. Also from Ghana, stay healthy. Bye-bye.